Dear Dr. Paul, Chairman of the conference, dear organizing committee, dear colleague, I'm glad to be here with you to share experience and to ask questions. The subject is treat a crowding and don't wake up the monster. We can see this is a monster for us. When we want to see a patient for orthodontic treatment, we want to give him the best we can. We don't want during braces or after braces to see any recession. This is like a failure for us. The patient will tell us this because of my braces, or the dentist, his dentist will say this because of your braces. We don't want this during our treatment. So the orthodontic treatment can be helpful for the gum. When we align the gum, we align the bone. Is it good for the patient? And it can be harmful for the gum if we wake up the monster. So with our braces, we can move teeth vertically by intruding or extruding. We can move horizontally by labial or lingual movement, or mesial or distal movement. And we can also rotate our teeth. When we put force on a tooth, this tooth will start to move, and with moving, we'll have this situation: a bone resorption from one side and a new bone from the other side, and this will allow the tooth to move. This is good. What are the factors that will affect the development of the gingival recession? When we procline the lower incisors, we have to control the amount of attached gingiva, the thickness of this attached gingiva. We have to control the oral hygiene to check the periodontal condition, and also to check the thickness of the alveolar envelope. We have a clinical study that showed results regarding the association between how much we have, the amount of the recession that we have, and the amount of the proclination of the incisor, or how much gingiva we have, or the oral hygiene, or the periodontal condition, or the thickness of the alveolar envelope. Let's talk about the factors, the risky factors. We talk about, first of all, age. We know all that if we treat adult patient, it's risky for the gum. If we treat young patient, kids, it's more safe to work with those patients. We talk some disease can affect the gingiva and the bone. Let's talk about the oral hygiene. We all know that the main factor guilty of having gingivitis is the plaque. Number of bacteria that around the crowded teeth are higher than the aligned teeth. So, because we know that the patient cannot brush very well his teeth, even if he wants to do it, but it's difficult. And also, when you put the braces, the amount of bacteria will increase. And we know why. This is also because it's difficult to brush. Orthodontic forces do not induce gingivitis. We have not to feel guilty about this. The plaque will cause gingivitis. If we put similar forces in a bad condition, a bad oral hygiene, those orthodontic forces will induce bone defects and will affect our gingiva. But if we work on a healthy, a good controlled oral hygiene, And if we work with respecting the biology of the environment, usually we don't have any problem, any recession problem. Also, if we control the plaque, we can work with the perio patient safely and have a good result. But we have to control the plaque. Always ask the patient to clean his braces and his teeth. Let's talk about the periodontal condition. We have two biotypes, the thin biotype and the thick biotype. The thin biotype, we talk about a thin layer of gingiva covering a thin layer of bone. We can see here the profile of the roots. And usually we have longer height of the teeth. The thick biotype teeth are with thick layer of gingiva. This is Kate, 14 years old. When we examine her teeth and her gingiva, we see that there is not enough gum around her lower incisors. And you can see also the profile of the roots. When we check the X-ray, we see as if we have already a mild bone resorption in this area. But we achieved a successful treatment with her, and we didn't do any gum recession. We have to have a minimum amount of attached gingiva before we start orthodontic treatment. Otherwise, our treatment will be, our gingiva, our gum will be compromised. We have to consider how much force we are putting on our teeth and the direction of this force, because tipping teeth is not good. We have to see that around, when we move teeth, around this teeth, we have bone resorption, we have a lot of events happening with our treatment. When we talk about the bone resorption, this bone resorption will happen horizontally. We have horizontal bone resorption. It's not bad. But if we have vertical bone resorption, this is bad situation. Let's see how it happens. We put braces. We start to move teeth. And with this movement, we have a vertical bone resorption, and we have horizontal bone resorption. This is the enlargement of the PDL. It's not harmful for the gum, but the vertical bone resorption, this is bad for the gum. The proclination, when we see the protrusion of the lower incisors, usually it's associated with thin gingival biotype. And with the thin biotype, we have to be careful about when we do braces. When we move the teeth lingually, usually the thin biotype will become more thicker. Let's talk about the anatomical factors. Usually, we want to see how much bone thickness we have before we start orthodontic treatment, especially when we have a case of thin biotype. CBCT is a good tool to measure. This is a printed CBCT. We see the amount of bone covering the tooth here. This is a case of Aisha. She has already braces, but look here. We don't have enough bone, and especially here, as if we don't have any bone covering the labial surface of the root. Don't panic. This is Aisha. Look at her gum before we start. We can see the gum is getting whiter when we stretch her, and we see the profile of the roots. But I put braces for her, and I try to use self-ligating bracket with IPR, interproximal reduction, to create space to allow for this crowding to get relieved, to get corrected. With this, I was concerned about her biotype, and I did my best not to procline her incisor, and look what I get from the CBCT, a bone resorption. This is another case of Diala. At the end of her treatment, look at her biotype. We can see the roots here, gingivitis, and poor oral hygiene. I removed the braces for her. Look again at her roots, the gum. I asked her to do CBCT, and look what I get from the CBCT. Lot of bone resorption. And with this X-ray, we can see how much bone we lost with our orthodontic treatment. Is this real? If it's real, it's very, we have to change our job. The CBCT is giving us, it's overestimating the fenestration. When we have a bone resorption on the CBCT, it doesn't mean we have real bone resorption. Because less than 1 millimeter of bone thickness doesn't show on the CBCT. So when we see on the CBCT that we don't have bone, it doesn't mean we don't have bone. Maybe it means that we have less than 1 millimeter of bone thickness. This is Chris, 20 years old. He came because he wants a wide smile. Look at his buccal corridor. And he wants to straighten his, especially the lower crowded teeth. When I examine his gum, I don't want to do any proclination for the lower when correcting this crowding. So we started to put braces, and we start moving his teeth. With, this is at the beginning of the treatment. Look at the crowding. It's becoming the correction. We have a correction here, slowly, without compromising look at the gum at the, it's not the end also, but the gum is okay. We don't have any gum recession, and we don't have any proclination, and the amount of attached gingiva is good. This is other view. We see also the gum here. We are not proclining, and we are correcting the crowding with the IPR, creating space between the teeth. We can see it better on the third view. When we put the braces, we create spaces between the aligned teeth. We'll talk about this in the workshop tomorrow. Look here, we have create spaces to allow the crowding to get corrected. Another patient, Carmen, 30 years old. She did braces before. She's having a retainer, fixed retainer on the lower teeth, but she removed her retainer. And look at her also oral hygiene. It's not good. We have crowded teeth to be corrected, and we have a thin biotype gingiva. We don't want with the correction to do any proclination because we will compromise her gum. I do cleaning for her. I put 2D bracket, It's also like a self-ligating. It's a low friction bracket. And I did interproximal reduction before I put the wire, and then I put the wire, and I started to move teeth. This is other view. Look here, we did IPR. We create space. The maximum we can do is 0.5 millimeter. And we have to keep the same shape of the tooth. We don't have to change the shape. And this is when we tell the patient that we will do this procedure, we say that we are not affecting the shape of the teeth with the stripping. This is after 1 month. The space is closing and teeth are more corrected, more aligned. This is other view. We see the correction without proclination. And look at the gum. We didn't affect the gum. Hoping so. This is other case, Rose, 55 years old. She had crowding. We correct and look at her gum at the end of the treatment. We didn't procline. We didn't change the amount of attached gingiva. So we are kind of safe regarding this gum recession. Let's talk about the mechanical factors that can be risky for our treatment. Mechanical factor, we're talking about brushing, the way we brush. You know that some patients are very aggressive when they use their brush. They want to clean, and they thought that if I be more aggressive, I clean better. It's maybe if it's acceptable for the hard tissue, it's totally unacceptable for the soft tissue, and this is a major factor to create a gum recession. So tell the patient to clean, but not to be aggressive. Orthodontic movement can be also a risky factor. Sometimes the patient refuses the ideal treatment plan that we are giving him. For example, in a class 2, the patient doesn't want any orthodontic surgery. He wants to do braces and correct his problem only with braces. So what we gonna do? Are we going to procline the incisor to correct the overjet and have a contact, incisal contact? If we will do so, we are doing a long movement for the lower incisor, and we are also compromising the gingiva. When we do braces, when we move teeth, we are moving not only the tooth, we are moving all the tissue around it, the PDL, the bone, the gum, everything is moving. If we move this tooth inside the alveolar envelope with a thick biotype patient, we are safe. But with a thin biotype, we have to be more careful about how much forces we are using and the direction of those forces. Let's see this video. We are moving the teeth inside the alveolar envelope with all the environment, the tissue around it, the bone, the gum, the PDL. It's moving with the tooth inside the alveolar envelope. Some studies show that there is no gingival recession after orthodontic tipping of the incisors. They procline, they correct the crowding, and they don't see any gum recession. The situation is like this. We are moving, we are proclining, and we are hoping that With the proclination, the bone is following the movement, and we have like a new bone coming here in this area. But is this real? Studies show that the major area where we have a gum recession is the anterior area, especially the lower anteriors. If we're gonna do a proclination, we don't have the same amount of the proclination with the same amount of recession. Sometimes we do a lot of proclination and we don't have too much recession, and sometimes we just align and we have too much recession. When we move these labially, we are displacing, in case of we are giving a positive torque, or we are bodily moving the tooth, we are losing vertical bone. We have vertical bone resorption. It's similar to this movement. Sorry. We'll see here. It will come, yes. We see that the vertical bone resorption with the proclination, and we thought that this is maybe the main factor that will produce the gum recession. Is the self-ligating bracket will help us in this situation? We know that self-ligating brackets will allow us to have low friction and better sliding mechanics. How can we use this in our treatment? We know also from the study that we have less proclination with those kind of brackets. When we have a crowded teeth and we want to align, we put braces. We start doing IPR in the area where teeth are aligned. So we're giving more room for teeth to be corrected. And progressively, when the crowded teeth are aligned, we can do IPR in this area. So we avoid this proclination. But if we don't do this, we just put braces on the crowded teeth and we put a wire, and this wire will do his job. He will align with a proclination, and this will give us this the monster, the gum recession. So to avoid this situation, start doing reproximation with the aligned teeth. We know that if we do this, teeth will move inside the alveolar envelope and will move mesially or distally, and will have the space closing, and teeth are more corrected. Micro. It will help, but we cannot say that we'll never have a gum recession, but it will help. In case if we compare the situation of we have crowding, we put the braces. In case one, we did this reproximation, we create spaces, and we put self-ligating brackets to avoid to have the low friction and better sliding mechanics. Okay, teeth will start to move. The other situation, case number 2, we have crowded teeth. We put a bracket, normal bracket. We put wire, and teeth will start to align. We don't have any space other than the proclination. This situation, case number 2, will have more gum recession than case number 1. But
I have a question.
Yes.
Jack Sheridan, who is the father of They call him Jack the Stripper. He strips the teeth. He's at our university. He's retiring this year. And so it's been a great learning experience. And this is exactly the way we treat cases to prevent the proclination. My question is, have you considered taking out a lower incisor on some cases because of so much crowding that even the IPR would not take care of that?
Yes, we can do. I also use this removing one incisor in case it's too much crowded and we have a thin biotype. We don't want to take any risk because even if we do this procedure, self-ligating brackets, IPR, the aligned teeth, and put light forces, we still have some proclination. It's better to move one incisor and closing these spaces. So we are sure that we are moving this inside this alveolar envelope. I started my topic by saying that I'm here to ask also, to share experience and to ask questions. This is a field we need research to have more answers for these questions. In this situation, we do prevention or better to wait the recession to finish, to come at its end and then treat her with the perio surgery. It's better to do prevention when we have especially a thin biotype, when we want to do a mild proclination. It's better to do a gingival graft or bone and gingival graft. But we don't know regarding the study don't show when is the best timing to do this. If you want to be on the top of the jobs and be happy and sleep without being worried about what you did in your days, don't wake up this monster, okay? Try to use light forces and review what I said before.
And what was the number 2 best job? It was dentist.
Dentist? Mm-hmm. Okay. We're lucky. Thank you for your presence. Turn it on.
This problem of resorption happened only in the crowding area or after you make leveling and you want to make traction for class 2 or class 3. We used rigid wire and we began to make traction. Is this happened also, do you think, or only in the crowding area where we work?
If we have the situation, it's aligned on the anterior, it's crowded on the premolars area. Okay, we are straightening those premolars without doing creating any spaces. We can also procline the interiors. Also, when we lose class 2 elastics, we're also proclining the lower incisors. What I do, I put a retainer, fixed retainer, when I finish the alignment of the anterior, just to be sure that I will reduce the proclination, especially when I will use the class 2 elastics. I always do retainer before I use fixed retainer. So I decrease the chance to have gum recession.
Excuse me, fixed retainer only lower?
Only lower, yes. Because I consider that if we fix this, it will become one block and it's difficult to move. So it will help. And we have to accept if a patient, a class 2 patient, surgical case, we cannot having a class 1 only by orthodontics. Our forces, our movement is limited. We have to accept this. We have to finish a class 2 cases in a class 2 occlusion. I study occlusion and I can say that it's not harmful for the TMG, and Dr. Enza will also correct me if I'm saying wrong. It's not something bad. Which is bad is to have this gum recession. It's very difficult to treat. You, Dr. Muhammad, you know this. Thank you.
Thank you, Michel. Thank you very much for your good presentation. Thank you.
Thank you.